Bonjour, hi. Welcome to the Nadine's Show, where we talk about social issues of all race and gender. Please comment, share, and like. Your feedback will be mostly appreciated. Come and join our team where we have great discussions. Welcome to the Nadine's Show.
I'm showing your Facebook thing, that's why. You see, it's not showing my...
Yeah, but it's okay.
So where would I press my...
Yeah, so you have to go back here and get your stuff. Yeah. Guys, okay, everyone is on. Yeah, you were right there. So you have to go casting. It was on.
But it doesn't work like this. We have to show from here. You have
Yeah.
to
Guys, I have to show you from here, okay? There you go. Let me, because it's not showing. Okay. Are you live now on Facebook? Okay. Hi everyone. Hi my Instagram user. Today we have a special guest and our topic is on breast cancer, but I was trying to see if I could stream it to the television, but I don't know, but something went wrong. So I'm just going to turn the camera so we could see it from here, okay? If you guys have Facebook, you can follow me on Facebook at Nadine, the Nadine Show, or Nadine Wilson, and you could see me, okay? So I wish all the viewers worldwide good afternoon, and today is August the 14th at 2020, year 2021, and so we're going to start now, okay? Thank you guys, and good afternoon to all. And thank you for coming on. You ready? I'm waiting for you.
Okay. So, hi everyone. My name is Lisa. I'm a technologist at one of the breast centers. So I will be giving a presentation on breasts, the different type of breast ways to image the breast. So this is all based on a technologist point of view. So I will be describing the different ways or modality used. For example, I will be explaining to you.
You can go live on Facebook.
Yes. So.
Okay. So just
1 second, please.
Yeah. Could you just exit that, please? Exit. Yeah, and show. Then go to Facebook here. That one, yeah, go Chrome, then click, go back over here, my profile, event, yeah, then click start, now go back, start live video, yeah, go up, yeah, you clicked it, because you have to share, okay, start live, what's happening?
Do you have, maybe you should have your phone off.
Hold on. Yeah, there it is. It's a little bit taking slowly, guys. Yeah. Hold on. It's a little bit slow, guys. Sorry about that. Okay, there. Okay. Okay. Remember, you have to go viewing so they could be able to go down. Yeah, go down. Allow viewer to message you. Yeah, okay, that's perfect. Then you could start live video. Okay. There, counting down. Hi everyone. And it's Nadine's from the Nadine Show. Oh, hi everyone, it's Nadine from the Nadine Show, and I have my guest speaker today, Lisa.
Yes.
And today we'll be talking about what do you call it?
We'll be speaking about breast imaging, the different ways or modalities to image the breast.
Okay, so basically, the phone is right here because we're trying to screen it from the television and it won't happen. So that's why we're doing it from the I'm doing it like this, but it's okay. So the reason why I decided to have a talk show today is because God is that, oh sorry guys, that's okay, yeah, sorry about that. So the reason why that we decided to have a show today is because I had some problems in the past, since recently, not really in the past. Like I saw my breast has cysts, so I went to emergency to find out what's happening, because it's really weird that I have cysts. And they said that okay, they're gonna do a biopsy, not biopsy, ultrasound,
ultrasound and aspirated,
aspirated,
yes.
Yeah. So eventually, that's what they did. So I only had cysts, but was a lot of fuel was in my breast. It was like a swimming pool. So that's what it was, like a swimming, but it was very painful. So, and I'm very happy that I got it done. So here we have Lisa. Lisa would like to give us some more information. She talked to us about the breast, what the breast is all about, for us women to be proactive, because, sometimes we feel pains and we're like, oh, okay, it's nothing, I don't care, or whatever, it's nothing. But don't be afraid to go. I know it can be very painful, but what I did when I went, the machine, the first one, which is that big machine, the first one,
the
mammo, that one squeezes your breast. Sorry about that, guys. That's the door. The wind. That squeezes the breast so hard. So what I did, she gave me a stool so I could start. It's more easier if you sit. But I don't know if your facility has that capability for you to do. But I sat, and it was so much better for me to do the test. And then afterwards, I do the ultrasound, and then I got my results. It was okay, just fluid in my breast. So I was really scared, but thank God. So I turn over everything to Lisa now.
Okay, so I'm going to give you a PowerPoint, and this is all based on a technologist point of view. I do mammogram, like for screening and ultrasound. So I just made this PowerPoint to show you the different breast type, to show you what imaging we use for the breast. And as discussed or mentioned before, we're going to have Dr. Shaista, who's a radiologist, and after the presentation, she'll be able to explain better the protocols for screening, etc. So I'm going to start with the PowerPoint.
Hey, it's working.
Please. Oh, good. It works.
It's working, guys.
Okay, guys, try it.
Guys, it's working now.
Okay, so I'm going to give you the PowerPoint now.
Hi, guys, it's working.
Just bear with me. Okay, there we go. Okay, so but we still have to look at it here.
Oh yeah, but you have to share.
You will need your phone.
No, you have to share the screen.
Okay.
Yeah. Could you go back? Please.
And
here you have to go back to the here. And you go
here.
Share screen. Yeah.
Share screen. It's already on.
No, the PowerPoint, you gotta go back into Facebook. Don't end it, go back into the Facebook.
Yeah, this is our Facebook.
Yeah.
Yeah, we're already in.
We have to share the document. Share file, remember what I showed you?
Mm-hmm.
Yeah.
I think that's gonna take a while. It's just
okay, she doesn't want to do that part.
It's gonna take a while. I'm not very adverse to this. So we'll have to show them with your phone if you don't mind. So
okay, here we go.
Okay, so this is the different modality we use for breast imaging, breast screening. So tomosynthesis, it's mammogram. It's just an app that we use. It's called 3D imaging. And we have ultrasound, and we have something called stereo and MRI. So I will explain all of these modalities, okay? But first, let's talk about the breast anatomy. So this is the breast. Our breast is made up of lots of breast tissue, lymphatic system. It's made up of fat, glandular breast tissue. We have the lobules, which is about 15 to 20 and these lobules turn into lobes, which becomes like ducts. And basically the anatomy of the breast is the ducts. We have dilation of the ducts when we are pregnant, when we're breastfeeding, and the evolution of the breast all revolve around hormonal changes, whether it's artificial hormones or internal hormones. So that's why you find sometimes when it's close to a menstrual cycle, we have tenderness of the breast. Okay, and now I'm going to talk about the different type of breast tissue that we have. We have three types of breast tissue. We have the fibrous connective breast tissue. That's usually in young women. And then we have the glandular breast tissue. Again, that's between women of childbearing age, so 35 to 50. And then the third type of breast tissue is adipose or fatty breast tissue, and that's in women after menopause. Okay, so I'm going to show you some images of the different breast type. So this is an extremely dense breast. This is fibrous and connective breast tissue. You will find that mainly in young women, but we do have exception with women after menopause, especially if you take hormones, etc. This is extremely dense breast tissue, and we say this is made up of this is made up of more than 75% glandular breast tissue, the extremely dense breast. So this is a mammo image. As you can see, it looks like cloudy sky. It's hard to depict any abnormality on this breast because it all looks like all cloudy. So most breasts that are extremely dense, we do ultrasound screening. Ultrasound will be able to pick up any abnormality. It differentiates the breast tissue. Also, mammogram is used as a best screening tool for calcification. Calcification is seen well on mammogram, not well on ultrasound. But this is an extremely dense breast. Again, like I said, made up more than 75% glandular breast tissue. This is a dense breast. This is Nadine's breast tissue. So as you said, Nadine said she had some problems with her breast. She ended up in emergency. She had to take antibiotics. She did the mammogram. Look at it. This is a dense breast. So this is, again, this is made up of about 50 to 75% glandular breast tissue. You have here, all of these are glandular breast tissue. So we say 50 to 75%. Looking at this, you cannot depict any abnormality, or you cannot see any abnormality on the breast. So again, a dense breast is, we use ultrasound to help us to depict any abnormality. And here we go again. Now I'll show you the ultrasound images of a dense breast. So this is how a dense breast looks on ultrasound. It's heterogeneously dense, and the anatomy of the ultrasound, this is the skin, this is the breast tissue, this is the pectoral muscles, and then this here is part of the lungs, or the pleural area after the pectoral muscle. Now this is Nadine's ultrasound. Remember, she said she had liquid, fluid, so these are called cysts. So cysts are a pocket of fluid. These are liquid that does not dissolve during the menstrual cycle. So you form these cysts. Cysts are benign. They're not cancerous. A lot of young people, you'll find cysts in the breast. Again, it's all part of hormonal changes. And you see how she has many cysts. She has big cysts, small cysts. On the ultrasound, we could not have seen those. And this is what we call a classic cyst. It's dark, so we call it anechoic. You have some true transmission. And then you have these different type of cysts. We call it complicated cysts. Complicated in the sense that you see this gray area here, and then we have this dark area. So it's very thick liquid that's in the cyst. So those are the complicated cysts, and this is a classic cyst. Classic cyst, classic. This has like debris in it, but these are the thicker liquid, complicated cysts. Okay, now the second type of breast tissue. So on the mammogram, this looked like partly cloudy, right? There are some areas that are dense, some areas that are glandular. It's called fibroglandular breast tissue. With this type of breast, you may do ultrasound as a backup if there are any changes compared to the previous mammogram, or if there are any new asymmetry. Like when we say asymmetry, meaning if you have areas that are a little bit more dense compared to the previous. And we could say, analogy, it's partly cloudy on a mammogram. And here's the ultrasound for a glandular breast tissue, fibroglandular breast tissue. And fibroglandular breast tissue are made up of 25 to 50% glandular breast tissue. Now, this is adipose breast tissue. And adipose breast tissue are mainly, should be, women after menopause. It's fatty breast tissue. On the mammogram, we could say clear sky. We are able to depict any abnormality on this breast. So most fatty breasts, we do not use ultrasound as a screening. Again, as I said, unless if there are changes or new asymmetry or a new nodule seen compared to the previous ultrasound or mammogram. So this is a fatty breast on the ultrasound, and it's easy to depict any abnormality in a fatty breast. Okay, I'll talk about the different breast parameters. So you know when you come to do your mammogram, look, there's technical issues. The live video has ended.
Where?
It has ended. So
no, it's okay. Yeah. Don't worry about that.
Oh, they're okay? So
yeah, they're on. Yeah, they're
okay.
on. Yeah.
Fine. Okay, so this is the breast parameters. So these are the areas that we need to include on the mammogram. So, you know, most of the time we complain that the breast mammogram is very painful, but we need to get all of these on the breast, on the plate, in the mammogram, okay? And they're just explaining the different positioning. So we have two types of positioning we do in mammogram. We do the CC, which is from upper, lower, and we do the oblique. And I'll go back to this one. Go back. Yes. So you find most of the time when we're doing the oblique, which is medial to lateral or lateral to medial, you find that we always take our hand and we touch in the breast and at the lower abdominal area where your abdominal wall touches the breast. Most people think it's about the fat or so. We don't notice that. This is an angle that we have to create when we do a mammogram, and it's called the inframammary fold. So this is the oblique, and this is the positioning for the oblique. And as I said, we need to do a CC for the upper and lower part of the breast. We do the oblique for the medial aspect and the lateral aspect. In the best way we know if we did a good positioning in a mammogram, we have this line from the nipple to the chest wall. So the difference between the CC and the MLO should be 1 centimeter. That way we know that's an ideal mammogram. If it's more than 1 centimeter or so, we know maybe we did not position well, but it's a borderline. And here, when I say CC, upper, lower part of the breast, we always have to include the pectoral muscle, because sometimes we have cancer in the pectoral muscle and we can miss that. So you find when we positioning and the grid is grading on your chest wall, it's really not to give you pain or to hurt you. It's to include the pectoral muscle on the flat CC. And here on the inframammary fold, we need to include the inframammary fold. We need to get the pectoral muscle in a nice concave line. So that's the correct positioning for breasts. And here the importance of positioning. So this is a CC, like I said, and here we have this bright dot here. So this is an abnormality, and really we caught this because we position it as posteriorly as possible. If we did not position very posteriorly, we could have missed this. So again, when we do a positioning, it's not because we want to hurt you, it's because we want to get as far back as possible.
So that thing right here, this thing,
that is
this thing here, this is what right here?
Right there.
This
is an abnormality.
Okay.
And on the mammogram, we call it asymmetric. It's very bright. And we look at the borders, it's kind of speculated.
Let's go closer, guys.
It's kind of speculated, so we will be worried. So somebody with a breast like that, we will send them to do an ultrasound so that the ultrasound could correlate with this.
So what's the difference between here and here? How do you know that this is abnormal?
It's brighter.
Okay, it's brighter.
Yes.
Okay.
You see, these are all even out. But, and then if you look at the border, it's a slight speculation, slight distortion.
Okay.
Okay.
And what are these lines here?
These are your vessels.
Your vessels there.
Yes.
Okay.
So you see the breast is made up of a lot of vessels, artery, lymphatic vessels, etc. Some of them are prominent on the breast. This is kind of like a fatty breast. So
okay.
Let's see. Okay. And now I'm going to talk to you about the mammo. This, we call it tomosynthesis. So this is a new application used in the States. They use it as screening. In the screening center in Quebec, I don't think we use it as a screening, but in a diagnostic center, it's used as a screening. So tomosynthesis is really a mammogram, but we call it 3D. It's a 3D projection. So what happens, it allows the breast, when we position, it does a projection where it goes in an angle, 15 in total, 7.5 one way, minus 7.5 the other. So it's sectioning out the breast. So what we can do when the radiologist is reading the mammogram, they scroll through it, and any overlap breast tissue, we're able to depict any abnormality in there. Okay. So I'll show you an example. This is a regular mammogram. We call it 2D. This is a mammogram done. This is a patient with dense breasts. You see this area here is very dense. We cannot see any abnormality with that in the 2D. If the radiologist will just say, okay, go do an ultrasound. Now, this is the 3D, the dimensional. So you see, it's kind of fuzzy here, but you can scroll down. So when you scroll down, when you scroll down, the overlap breast tissue spreads. And here we think there is a nodule here, we call it, or some abnormality, where the arrow is showing you here. And this is the oblique position. Now in the CC position, which I said from head to inferior, we can see the outline very well. So we're convinced there's a nodule here. Do we know if it's a cyst? Do we know if it's a solid lesion? So what we'll do is the radiologist will ask for an ultrasound to confirm what exactly is this.
What's that there? What's that?
This is the nipple. So you know, sometimes we put the
the thing,
a little marker there to see the nipple in profile.
Okay, so that's
the marker. This one doesn't have a marker, or because we have it in tomo, the marker is not highlighted.
Okay.
So we'll do an ultrasound for this patient to see what abnormality is that.
Okay.
Okay, so now breast ultrasound. So breast ultrasound is just sound wave, that's radio frequency. We use a transducer, and we have different transducers. So the breast is like a very superficial tissue, not like when you do the abdomen or the pelvis. So We use usually the transducers like 12/8 because that way we get a better definition of any abnormality. The breast is superficial, okay? And what are the characteristics we're looking for when we find something in the breast on the ultrasound? So an ultrasound, we look at the shape. Is it round? Is it oval? Is it irregular? So something that's round, maybe oval, we say, okay, it could be benign. Something that's irregular, speculated or so, we could say it's suspicious or it's malignant. Then we look at the margin. Is it well circumscribed? Most cysts or benign features are well circumscribed. Indistinct, speculated, microlobulated, angular could be suspicious for malignancy. Some benign lesion could be microlobulated as well, like fibroadenoma, etc. We look at the orientation. Is it parallel, meaning parallel to the breast, the breast wall, or is it non-parallel, meaning taller than wide? So something that's parallel, like to the breast lining, we'll say it's very benign. Something non-parallel, taller than wide, we could say it's suspicious for malignancy. Then we look at posterior acoustic features. So example, I'll go back. You remember when I showed you the cyst of Nadine, and I said to you, you see that through transmission, like you see a brightness going through. Let's go back. Here.
So that's my breast, right?
This is posterior enhancement through transmission. You see this, just this area here, where it's bright.
Okay.
So typical cyst has true transmission, meaning the frequency will go through. Okay. So this is what we call it. And then shadowing, again, if it's dark here, we say it's shadowing, dark. But this one is true transmission. So I'm just trying to tell you about the posterior enhancement. So we're looking at anything under the lesion. This is called posterior enhancement, okay? It could be bright, which is true transmission. It could be dark, which is shadowing, okay? So let's go back. Oops. Okay. Yes, so or we have combined patterns. Okay, we talk about the boundary. Is it abrupt? Is it echogenic hollow? Meaning there is nothing shadowing, like what I showed you in that previous image. There are no shadows in the posterior part of the lesion. An echogenic hollow, meaning at the edge of the lesion, if you have a circle at the edge, you have dark lines going down. So this is what we're talking about. And in ultrasound, we call it echogenic patterns. So we describe it either something hyperechoic, meaning bright gray. Anything that's bright gray, it's not very suspicious. It could be benign features. Anything that's hypoechoic, which is dark gray, it could be suspicious, but then again, it's all a combination of the shape, the margin, the orientation. Then isoechoic, meaning the breast tissue are the same and the lesion are the same grayness, okay? Something complex. Complex meaning you have either this pattern, hypo, which is dark gray, or bright gray, with darkness, which is anechoic. And anechoic, if a lesion that's very dark, like I showed you Nadine's cyst, it's anechoic. Anything that has cysts in it, it's anechoic, it's dark, okay? So here under ultrasound, okay, what's wrong? So here ultrasound, I'm showing you this lesion. So we'll describe it using one of the description. So this is hypoechoic dark gray. The margin is well defined. We have a little bit of true transmission. And when I spoke to you about edge enhancement, when I said there's a little gray coming from here, that's what's going on. Okay, so this is a description characteristic of a lesion on the ultrasound. Now we're going to talk about stereotatic. It's a biopsy, and this is only for calcification. The breast is made up of calcification. Some breast has calcification, and some of these calcification could be malignant. There are different types of calcification, and whenever someone has calcification, the radiologist compare the previous images. If it's new, then they're going to do further workup, or they may ask for a biopsy. If it's increasing calcification, they're going to be worried about it. So what is a stereo biopsy? So stereo biopsy, it's like a mammogram, but we use a vacuum assisted gun, which is like a 9-gauge regular gun, to get the samples of these calcification. And the biopsy could be done either sitting or lying on your stomach. And you go through different approach, meaning you go from medially, you go from laterally. When we say craniocaudal, you're meaning up to inferior, from the top of the breast to the inferior part. When we say craniocorneal, from under the breast to the superior part of the breast. And the stereo, we're looking for the calcification. Some calcification are in lesion. Some calcification comes with distortion. So we try to target that area, and we do a cross-sectional. So we have an X, which is like the horizontal part in the area that we're going for. We have the Y, which is in the vertical, and the depth is really where the lesion is. So it's like a cross-sectional procedure. And we get these samples for the calcification, and we send it to pathology. So example, this is a mammogram. Like I was saying, this is how the calcification look. You see how very, very small it is? So this is why we said not all calcification can be seen on ultrasound, sorry. This is why a mammogram is the best modality for calcification. Very small calcification. And we did we took samples for the area. Here is the calcification. Again, very small. This is the sample. We send it to pathology to be analyzed. Okay. And then here's another modality, or another way that we do imaging for the breast. This is called MRI, magnetic resonance imaging. And we use radio wave along with a computer. We use a subtraction application. We use contrast or without contrast. So they put gadolinium in intravenously. They put gadolinium. It's about 10 cc's, and it goes according to your weight. You know, if you're 130, 10 cc's. It's about 10 cc's used. If you want 39 cc's, if you're less than 130, I think it's the other way around. We use 10 cc if you're 130 pounds. If you're less than 130 pounds, 9 cc. And the position for MRI, it's lying on your stomach, and the breast is placed into a hole, and we do the imaging. And as I said, we use a special application, which is different mapping and subtraction and colors to highlight any abnormality in the breast. Can you pause?
Why?
And start over? People said it didn't work.
Oh, they can't get on? Mm-hmm. So you pause, right?
Okay. Are you on?
Yeah, I'm on live. Yeah.
Okay. So MRI, why do we do MRI? MRI, we do it for people who have very dense
I'm on
breasts.
live on
Okay. We do it for people who have very dense breasts. We do it for people who have implants. We don't use contrast with people who have implants. We do it for the extension of the diseases. For example, if a patient is diagnosed with breast cancer, we do follow up to see if there are any other area in the breast that has cancerous cell, because as I said, we use the contrast as well as a different subtraction. Here, 1 second. Here, let's try to go back. We haven't been.
Alright, go back to the screen. Yeah. You start live video, see? Start there. Yeah. Screen sharing. Yeah. Click here. Click sharing. Yeah. Click here. Start sharing. Yeah. And just, yeah.
Yeah, it's coming on.
Yeah.
Sorry, we're just waiting. I think our Facebook
Let's close that part.
people got cut off. They were having technical problems.
Yeah. Then you go live. Go live because it's supposed to start showing now. Yeah. Go live. Yeah. There you go.
For some reason, when we do the PowerPoint, I think
Yeah. Go to the PowerPoint now. Yeah. What's
this page
happening?
is not available. Right. This may be because of
Facebook, yeah, something is wrong. Reload again. Waiting for camera. There's camera. It's coming up. Okay.
That's technology for you
Guys, we're also doing it live on Facebook. So that is why they just contacted us that they cannot see it on Facebook. So we're just trying over here. But thank you guys for coming. It's really interesting. It's really, really interesting topic. We're still having some issues. Oh my God.
It's very slow.
But it's amazing, eh? Women, we have to go through a lot to take the ultrasound, the MIR, and the one that you squeeze the breast, that
Mammogram?
that mammogram, that one is very painful. I'm going to ask her some questions, and you guys should be able to on Instagram, because I know a lot of you guys want to come on to ask Lisa questions, and also Dr. Sherika.
Yeah, but she wasn't able to get on because of
We also have Dr.
Shaista.
Shaista. She also wanted to come to answer questions and to explain a lot more about breasts. So, but see, still going around. Oh my God. Oh.
Okay, maybe we should just continue with
Instagram.
Yeah.
Okay, and then we do Facebook another time then. Yeah, because something is wrong. It's still going around. It's not stopping. Because we want to share the PowerPoint, and we can share it, but it's not going. Okay, guys, so we're going back to our PowerPoint. Okay.
Wait 1 second.
Okay, there we go.
Okay, so I'm gonna go back. So I got to sorry for the
interruption.
So I was at MRI. So I just want to show you a few images of MRI. So that's the stereo, and that's the MRI. And here, so this is how the MRI looks. So this is a breast that was done, and you see this distortion here. It's well highlighted. Its contrast is used, and this speculated high contrast lesion, it's considered suspicious or something possibly malignant. So for sure the patient had a biopsy done, and they wait for the result. Okay, so I'm just going to go briefly to tell you some of the benign findings that's found in under ultrasound. So we call something like PASH, fibroadenomas. A lot of people have these. So PASH is like it's called pseudoagematous stoma hyperplasia. This is just fibrous breast tissue. It's a rare benign lesion. It's usually in women in childbearing age. And most of these lesions, when we say palpable, you can feel it. Okay, here, this is how the patch look on a mammo imaging. So you see this highly contrast lesion. You could see its benign feature. This border here is well defined. So that's the mammogram. That's the CC, upper lower breast, the oblique, medial lateral. It's the right side. Now under ultrasound, you see this lesion here? This is what it looks like. So how would we describe it? We'll describe it as hypoechoic, you know, the gray area, dark gray area, and echoic, anything that's dark, it's liquid in there. So we could say it's a complex lesion. And look at the border, well defined. So this is a benign finding. This is PASH, okay? Here we have fibroadenomas. So these are lumps found in the breast. A lot of young girls as young as 16 feel these lumps. They're palpable, meaning you can feel them. Mobile, meaning they move upon touching them. Non-palpable, meaning you don't know they're there unless accidental imaging. Okay, common in young girls, premenopausal women. And these are well-defined lesions. On ultrasound, okay, let's show you. Okay, I don't have an image for a fibroadenoma on ultrasound, but we'll jump on to a hematoma. Hematoma, it's like benign breast tissue. It's like breast tissue that become very hard, lumpy. It's usually made up of glandular, fibrous, and fatty breast tissue. It's a developmental malformation. But again, this is very, very benign. It's not worrisome. Under a mammogram, here you have this area. It looks kind of lucent, and the border is well defined. It's a hematoma. Now, under ultrasound, this is how it looks. So you see, it really looks similar to the breast tissue. You just have the outline of the border. So when I said something is isoechoic, meaning the same sort of grayness with the lesion and the surrounding breast tissue. So that's a hematoma. It's benign breast tissue, okay? Now we're going to talk about gynecomastia. Gynecomastia, it's common in men, male. Gynecomastia, you have older men that has breast tissue developing mainly around the nipple. They might feel tenderness, they might feel like a lump or so. Gynecomastia comes with sometimes, most of the time, medication. If you take in prostate medication, antidepressant, if you smoke marijuana, if you take in any medication for alopecia, if you take in any supplements, proteins and bodybuilders and stuff, you may have breast tissue developing. That's gynecomastia. That's how it looks under ultrasound. It's just breast tissue that's increasing around the nipple area. So this is a mammogram of a male. This breast is fine, and you see this increased density here. This is more breast tissue. So that's gynecomastia. It's always around the nipple area.
What does that mean?
Gynecomastia, it's breast tissue, increasing in breast tissue in male.
Okay, so that's a good sign that
it's not
or bad
cancerous.
sign.
It's not cancerous.
Okay,
it's
so
not.
Just extra tissues?
Yes.
Okay.
And again, this is how it looks in the ultrasound. Usually one breast might have more breast tissue than the other. And then you have teens that during puberty has gynecomastia. Like you remember when we girls as teenager, we had a little budding when we close to puberty. Guys, young kids as 13 years old have increased glandular breast tissue. That's called teen gynecomastia.
Does it pain? Is it painful?
It's very tender.
Okay.
And I'm just going to show you, I'm going to end here, but I'll just show you, this is a 2D image. And this is like a breast.
This is the end of the slide?
Dense. Yeah, a dense breast. So this is a 2D, and like I said, when you do the 3D, which is the special tomosynthesis, you see you have more of an outline of these nodules in the breast. And this is what it looks like under ultrasound. It's cysts. These are classic cysts. It's liquid in it, and it's dark and echoic. Okay.
So what is that? What?
In here, it's
Yeah.
liquid that's in there.
That's fluid, right?
Yes.
Okay.
And then we're going to talk about another benign or malignant lesion found in the breast. It's phylloidy tumors. So it could either be benign or malignant. And this is all connective tissues. It's common in women 30 to 40 years old. It grows very quickly and palpable. You can feel it. It has similar features as a fibroadenoma. So this is an example. This woman, she was busy taking care of her mom. The breast was increasing, and painful, but she had no time to take care of herself, like us, a lot of women do, and we do not want to go have a mammogram if we don't believe in it, or we hear stories about it being painful. So you see this whole breast, it looks like she has implants. This is a mass, a phylloidy tumor. It's benign, but it picks up the whole breast.
Right here, like over this side?
whole area here.
That white part here?
Yes, it's a mass in the breast. And here, in the tomo, this is how it looks. It looks like a breast with implants, but it's a mass. This is how it looks in the ultrasound. It covers the whole breast. This is the breast tissue, but it covers the whole breast, so it's hard to even image it on the ultrasound. This is how it looks in a CT chest. So this is her one of the breasts that has the mass. Look at the other breast. You don't see anything. And some of you may not like it. This is a surgery. They had to take out the whole mass, so the whole breast came out. And then to put it back, they had to take breast tissue going all the way down to the groin to really stitch it up in the abdominal wall to put it back.
So hold on. So this is the breast?
No, this is the abdominal wall. This is up the chest where the breast was. But because they took out all of the breast tissue, they had to take tissue from the breast, from the abdominal wall to stitch it up.
Okay.
To get it. And we do have breast tissue in the groin area. We have the milk ducts leading to the groin area as well. Okay, so that's it. I will end it here. These are just other mammograms with the cancerous feature, but we'll end this here and we'll open for questions and stuff.
Okay, everyone. I'm going to switch the camera back to us. Can you all let me get this done? You can say hi to the audience. Oh, here, it's back on over here now. Yeah, I told you something. See, we're on live over here now.
Okay,
I don't even know what's happening, guys. To be honest,
I would end the slideshow.
Yeah, it's on over that side of the. It's on. Look, yeah. I don't know, but anyhow, we're over here. Yeah, it's on over there. Okay, so I know everyone has questions. Hi, it's Nadine and Lisa, but Dr. Shaista, she wanted to speak to the audience. However, we can't get her because Facebook is
still
it's still going in circles. So anyhow, if viewers want to come on, I could add you and you could ask Lisa questions, and hopefully we could get Dr. Shiraka back. Okay, guys, because I know a lot of people were waiting to ask her questions, including myself, because I know women that has breast cancer, and we want to know all about breast cancer and everything, because no one wants to go that way. It's very scary, which thank God when I went to the hospital, when I felt that those lumps, it was really scary, but it was all liquid. Yeah. What causes that liquid?
We don't know what well, like I said, the breast is made up of lymphatic fluids, and could be the lymphatic fluid that did not dissolve during your menstrual cycle, so you cause these liquid. But guys, I am answering on a technology point of view. Okay, so
put her on IG. Yes, I have a question. Yes, I'm going to take questions. I'm going to add viewers now who wants to be added. Okay, I see Teresa. I see I saw this gentleman, Chef Rod. I'm going to add him too. And I saw this lady first. I had you guys. But I have to say thank you. I have to say thanks for Dr. Shrek, Shaista, who wanted to come.
She wanted to come on, but she's
Yes.
having technical problems with Facebook. Look, Facebook is still.
We're still in the circle. So, oh my God, we have to have a second show.
I wonder if we shut down and come back up.
Yeah. Okay, you want to talk to your audience,
Sure.
please? Hi, Teresa.
Hi.
How are you?
Good, and you?
Hey there, how are you?
I'm good. How are you?
I'm doing well, thank you. Nadine, couldn't you add the doctor on IG? Have her live on IG?
She doesn't have an IG account.
Oh, okay.
She doesn't have an
Okay,
IG account, so that is
okay, I see. Okay. Yes, I have a question. So I did I went and I had an imaging done, and there I had a lymph node under my arm.
Yeah, it's normal to have lymph node under your armpits. You have lymph node under your armpits, you have in the chest wall, the thoracic lymph nodes. You have lymph node on the lateral aspect of the breast. We call it intramammary lymph node. These are normal lymph nodes.
Oh.
We're worried about them if they increase, if they get increase.
Okay, because what happened is, what I've noticed is that when I'm getting a cold, when I have like a cold or a little flu or something,
yes,
I feel them in my neck, like right here. I feel like
large because it fights the lymph node fights the infection, right?
Oh, it fights like the flu, like when I'm having a flu or a cold.
Yes,
I feel it.
Yes.
Oh, I see.
It fights the immune system, the lymph node. So if ever you have a flu or something, you find in that area or some kind of something, you find a lymph node close to that area will enlarge.
Oh, okay. So the lymph node under the arm is normal to have a lymph node. It's when they increase that you have to check it.
Pardon me?
No, I said it's normal to have the lymph node under your arm, under your armpit, but when they start to increase, that's when you need to be worried.
Yes, if they're
not worried, but have them checked.
Yes, yes.
Okay.
Yeah.
Okay. That was my question.
Okay, good.
Okay.
Anyone wants to ask questions? Don't be scared. I know breast cancer topic is a really sensitive topic, and many people are scared to ask questions regarding
One more question. I think probably people will identify with this. Is it okay? I chose not to have a mammogram, but instead had a sonogram.
You? Speaking about you? How old are you?
I chose to have 51.
51?
Yeah.
Okay. But what they start screening at 50 here in Canada. Yeah. In the States, they start at 40. And usually they say if your mother had breast cancer, you start with screening 10 years to the age she was diagnosed.
Oh, no.
So, but the thing about it, a lot of people opt for ultrasound because they don't like they hear stories or they don't like that the breast.
That's what I heard. Yeah.
But I'm telling you, mammogram is the best, not the best modality. Ultrasound, MRI, all of these complement each other. The mammogram, but it's always good to start off with a mammogram as a baseline. Like we said, we all have calcium deposit in the body. Yeah. And we do have calcium in the breast. So if you have calcium in the breast, some of this calcification could be malignant, cancerous, but you may not see it on ultrasound. So it's always good to do mammogram as a baseline, again, to pick up calcification, but then again, just to see a distortion. You may not see it well on ultrasound.
On
Some cancer,
ultrasound. Okay.
some cancer could be with distortion. Some cancer could be speculated, like spider or so. You may not see
Okay.
well on
And
ultrasound.
you wouldn't see that on an ultrasound.
Unless it's depicted on the mammogram and you pay particular
Oh,
attention in that area.
okay.
So,
Okay.
that's it.
Okay.
There it is.
Okay. Okay. Thanks. Okay, that's great.
There it is.
That's great.
People on Facebook, if they can see.
Can you send your Instagram thing to Dr. Shaista?
Yeah. The doctor wants to come on. Hold on. She's gonna come on show, guys.
Oh, that's great. She's coming back on?
Yeah.
We'll try and see if we can get her on Instagram.
Yeah.
Because the Facebook is not working well.
Okay, I went on Facebook and I share the images.
Okay. Okay. Any more questions?
Teresa? Okay, let me read. Okay. Any more questions? Guys, we're gonna have Dr. Sharik. Guys,
Shaista. But we have to.
Yeah. Sorry guys, I'm trying to look beneath the here. No, I'm not. Oh Jesus. Why does it have to happen today? Why Facebook today?
Facebook acts up sometimes. They act up sometimes.
I'm not stop sharing. Okay.
Okay, so
she got it. We're waiting on her. Okay, let's talk about you call it benign
things that are not cancerous. Yes.
Okay, so benign comes in what? Liquid? It's a liquid.
Well, cysts, which is liquid, it could be a benign. Like I said, we have the fibroadenomas. A lot of young people feel these lumps in their breasts. Like we said, some of them they move mobile, they move. Some of them are palpable, meaning you can feel them. And those things we follow up. We follow up with 6 months ultrasound for a 2-year period. If that person has a family history, they may tend to biopsy it. So they just follow it for a 2-year span every 6 months for stability. Such things like fibroadenoma, PASH, hematoma, etc. He's still trying to get on.
Okay. I do have to use Facebook.
No, sometimes Facebook come through, sometimes.
Okay.
Just,
the guys, you talk about the guys that has the gynecomastia.
Yes.
What happened to girls?
Well, we have breasts, we have glands, so this is not really a part of the female, it's the male gynecomastia.
Okay. So the male is different, the male breast is different, they have different lumps.
Well, it's a different anatomy because they don't have milk ducts, they don't have these ductal lobules, etc., right? We are the reproductive, so we have the glands, the ducts, and to help us to reproduce and produce milk for lactating, right?
Okay.
In the women.
Okay.
Yes.
So the guys, they have a different, and for teenagers, so what age does that, what age do they have?
Puberty. Some people start puberty like 12, 13, 15, it varies.
Okay, so that thing that's inside of the breast,
it's just gland. It's just your gland.
Would it grow bigger that they require to get an operation?
I don't think so. With gynecomastia, I don't think they have surgery. It's not something malignant. It's just the gland. If whatever medication they're taking, maybe when they stop, it disappears. The tenderness goes away.
Okay. That's interesting to know. Yeah, but I heard of boys that has to do operation and they have to remove lumps from their breast. Have you heard about that? before I heard boys did operation and remove lumps from
I've
the
never heard of.
leg.
I've never heard of that one. No,
Yes, I heard
not
of
personally heard. No.
yes. Teenagers.
Okay.
Oh,
Yes, I heard. So what would cause that? The lump? What?
I'm not sure about
Because
that.
every case is different. Case by case is different.
Yeah.
Okay. Okay. Yeah. So interested.
Yes.
But okay, for example, for my breast, I'm using my breast as an example, everyone. When I went and that liquid, can that liquid become harder? Can that liquid become, solid as a rock?
Well, no, because it's just liquid. Like I said, it becomes thick. So we call it complicated. It comes pussy like.
Pussy?
Yeah.
Like
very thick liquid.
You heard that, guys? So that
it could be brownish, kind of pale color or so.
Okay. Yeah, I remember when they removed that liquid, it was brown. The color was brown liquid from my breast. Yeah.
Yes, that's the color of the cis liquid in it. It's brown. But if it's thick, it could be like thick, like mucus.
Mucus. Okay.
Yeah.
But it's not cancerous.
No.
It's just cis. Well, that's really painful. Cis is really painful.
Wow.
Okay, so
Wow.
Shaista is on.
Oh, Shaista is on. Hold on, guys. Doctor. Okay.
Dr. Shaista?
Yes, we found her. Yeah, that's her. Yeah. Yes, Dr. Shaista is going to be on.
Yeah, put her on.
Yeah. I did. I add her. Yes. I sent her a request. Tell her that I sent her a request. Yeah, tell her I did send her a request. Yeah, I did send her a request.
Okay.
Tell her to send another one again.
I can't.
Yeah. Oh, there she is. Yeah. Yeah, I sent her an invitation. There it is. I sent it to her. What's her name? Let me spell it out.
S-H-A-I.
No, her name that she used.
S-H-A-I-S. Oh, the name that she used?
Yeah. I just added her. I sent her a request. Ask her to send another one again, please. We're trying to get the doctor on. Hold on, let me write it down. Okay.
What is this one? Here.
Okay, it's working now?
Not sure.
Oh, there she is.
She's made it. She made it.
I have been trying. See, this is my laptop with both of you guys frozen there.
Yes. Facebook, I have no idea. It's not working.
Circles over here.
Yeah. It's okay. So I was listening to a few of the questions.
Yes.
So yeah, thank you so much. So I'm working as a breast radiologist at the Health Sciences North in Sudbury.
Okay.
And which is affiliated with the Northern Ontario School of Medicine. So we have a very heavy breast screening program.
Oh.
Yeah. And I was listening to some of your questions, like specifically, I will answer the last two, but other questions then you can ask me and I'll be happy to say something. So you were talking about gynecomastia or gynecomastia, both pronunciations are correct. So what happens is that the male breast does not have glandular tissue, glands. Glands are that tissue that produces milk, and it's natural to a female, but it's not normally seen in men. So as men age and their testosterone decreases, the male hormone decreases, and estrogen increases, they kind of develop a bit of glandular tissue. And then we call it gynecomastia or gynecomastia. And then you see it it's like a flame shaped behind the nipple on a mammogram. And on ultrasound, you just see it like a female glandular tissue. So what happens is that males, then they develop breast cancer because breast cancer always develops in that glandular tissue. So you will see male breast cancer. Yeah. And
Good.
they develop lumps. So in young children, like boys and girls, so whenever the children are born, what happens is that there's always some hormonal imbalance. Their estrogen is more, their testosterone is more, like that. And then children also develop lumps in breasts. So yeah, so children can develop them, men can develop them, men can have breast cancer. I haven't seen a child with breast cancer, but they have cysts and other things. So cysts, they are of different types. There's a completely simple cyst, then there is a complex cyst, and then there is a solid and cystic thing. So this simple cyst, usually it will not give you problems. When is it going to give you problem? It is going to give you problem when it is really big. Like the pressure is so much in it that you have discomfort. And then when a patient says that we have pain, we have pressure, they can feel it. Then what we do is we put a needle in and we remove the fluid. So that it becomes easy for them to tolerate. But most of the cysts are asymptomatic. I would say 90%. They don't cause you problems. And many women have them, but they don't know that they have them. Then the other complicated cysts are those ones that have hemorrhage in them. They have some soft tissue in them. They don't look simple. So for them, we follow those up. We could follow them like at 6 months, and then 1 year. So at 2 years, if a cyst is stable, then we can return the patient to normal like screening. And then for the complicated cysts, I mean, like they are solid and cystic, those are the ones you have to biopsy because those ones can have cancer in them. So these are the type of cysts. So these are the questions I heard when I was trying to log on. So,
Yes. Well, good.
Did you hear the one that I asked about lymph nodes?
No, I didn't hear that.
I did a ultrasound, and she saw a lymph node under my arm. So I want to know about lymph nodes. Okay. But the other lady, she kind of explained it to me a bit.
Okay, so lymph nodes are normal structures. They are present in our entire body, and wherever they are present, they drain the fluid from that structure. Like for our ear, there are different lymph nodes. In our neck, we have different lymph nodes which drain from our mouth, from our tongue, from our throat, everywhere. So for our breast, the axilla is the main one. Our armpit, that is the where the lymph nodes go. Now, what is happening is that normally in women, these lymph nodes are a bit more bigger than in males. The reason, there are different reasons. Because we kind of have more inflammation and other things going on. So normally in women, they are going to be lymph nodes are going to be slightly more, but there's a cutoff limit. On ultrasound, when we do ultrasound, we know which one is abnormal, which one is normal, then they are borderline. Nowadays, the biggest problem is COVID-19 vaccination. So what happens is that every woman who gets vaccinated, she's having lymph nodes on that side. So it's a very common thing, but we are not worried because what we do is, depending upon how big the nodes are, usually we're going to say for the woman to come back in 1 or 3 months, 1 to 3 months, and then we see they start coming down. If there are lymph nodes everywhere, she had the vaccination on the left, but there are lymph nodes on the right, there are other lymph nodes in the neck, then you don't have to wait. That means that is something else. It may be due to COVID, but it can be due to other problems, so you need to exclude it. So these lymph nodes, they become enlarged when there is infection, when there is inflammation, when there is stress.
Oh, yes.
Lymphoma, when you have lymphoma, when you have breast cancer. So they can become enlarged due to multiple causes. Sometimes a lymph node is how we catch a patient has a breast cancer. We look and there's an enlarged lymph node. We biopsy it and it says breast cancer, but we don't know where the breast cancer is.
Okay, so I was telling the other lady that whenever I have a cold, whenever I'm getting a cold or the flu, my lymph nodes in my neck, I feel them when I have a cold or flu. I was telling her.
Yeah,
Okay.
that is exactly right. But if you feel them persistently enlarged, then you need to visit your doctor. And
No, just when I have a cold. Like now, I don't feel them because I
yeah,
don't have a cold.
yeah. That's okay.
But
That's
whenever I do, I feel them.
yeah, that's okay.
When I'm fighting
Yeah,
anything,
Mm-hmm.
I feel them.
exactly.
Popular.
So,
Yeah.
Exactly.
So we call them lip nodes.
lymph nodes.
Lymph
Lymph
nodes.
nodes.
Yeah.
Lymph
What,
nodes. Yeah.
doctor, why, I know this is new and it's a sensitive topic when someone mentioned the word COVID. It's very sensitive. However, but why now, what, do they know the reason why, some people are having lip nodes after taking the vaccine?
Why the lymph node
I
have
Yeah.
think that lymph nodes
enlarged.
are involved in the immunologic system, like immune system of the body.
Mm.
Because they try to, like any inflammation, any infection, anything, they become enlarged and they try to stop it. So when we are given vaccinations, it's a kind of a, like you're introducing something into the body so that you develop an immune response. So I think that is why some people are hypersensitive to small things also, and they will show bigger lymph nodes. And some people, nothing happens to them. Everybody does not develop them. So everybody's body is different. So I think it's just kind of a reaction of the body to these lymph nodes.
Okay. Okay.
Okay.
Thank
To
you.
these
Okay.
vaccination, sorry, reaction of the body in the form of enlarged lymph nodes to these
Mhm.
vaccines.
Oh,
Okay.
Yeah.
Thank you, doctor. Thank you.
And
okay.
just to
That's
go
really
back
good to
to,
hear.
Shaista, Dr. Shaista. I'm so used to calling you Shaista, sorry.
Just call
Okay,
me Shaista, Lisa.
just to go back to Teresa. So, she said she's 51 and she opted not to have a mammogram. Okay. So
Okay.
can you explain to her why it's important to do a mammogram and
I had an ultrasound instead.
to start off with a mammogram as a baseline? And,
Okay.
and if you could just give roughly the protocol for screening mammograms, please.
Okay, so what happens is that in US it's 40 years, in Canada it's 50 years. So we start baseline screening. This is an average risk woman, average risk, who doesn't have a family history of breast cancer and who does not have what you call it. Any risk factors. I will explain that separately, what high risk women are. But I'm talking about an average risk person. So an average risk person in Canada, they say you should start screening by 50 years. 50 years means that 50 years you should have your first mammogram. Now,
Mm-hmm.
what does the mammogram do? It's X-ray. And different provinces use different things, but in Quebec you have tomosynthesis also, and you have the standard mammogram also. So what tomosynthesis is, a 3D view of the breast. It's X-rays, but it makes 3D images. And then what you do is you actually scroll through the breast and you can see things like, you see them on cross-sectional imaging, like in three, you can see them in 3 dimensions. So it's very good and it misses less things. So what happens is that what is the use of mammograms in screening? What does ultrasound do? What does tomosynthesis do? And what does MRI do? These are 4 things I'm going to explain to you, okay? So first of all, mammogram. Mammogram is X-ray. It's going to show you masses. It's going to show you asymmetry. Okay, so mass, everybody knows what a mass is. Mass is anything that has borders and looks either ill-defined, well-defined, but it is something that is abnormal. A mass could be a cyst, it could be a cancer, it could be a fibroadenoma, any of those, okay? So when we do a mammogram, we see that a mass borders doesn't look good, they're irregular, then we know this is suspicious. We need to do an ultrasound to see what it is. Okay, so then what does asymmetry mean? Asymmetry means that the breast at one aspect is different from the rest of the breast and from the other breast. Asymmetry, something that does not match. Symmetry is both sides same or both, all the breast. So the mammogram shows us an asymmetry. Now there's another thing that is called architectural distortion. So what is that? Architectural distortion is when you don't see a mass, but you see irregularity and an appearance that is very abnormal from the rest of the breast. We call it architectural distortion. Distortion means anything that is distorted, basically. So that mammogram shows us. These are those things: asymmetry, architectural distortion, and microcalcifications, which we can see only on mammogram and tomosynthesis. We cannot see these on ultrasound, okay? Now, some of these things we may see on MRI. I will tell you what we can see, but MRI is very expensive and it's not going to be available to everyone, okay? What is available to everyone and what is the best screening tool is the mammogram. Like, we are lucky in Canada, it's free for us. Any person at 50 years or above can go and get it done. So that is what mammogram is, and it has a lot of advantages. I diagnosed, I think in 1 month, at least 10 patients with breast cancer on routine screening mammograms. Just routine. They did not have symptoms.
Okay, question. Are you guys using Tomo over there as well?
Not yet. Not yet.
Okay.
Because for screening in Ontario, Tomo is not yet, they have not allowed it. They have not allowed
yes. Okay.
for screening. So I'm just talking about screening. So now, what does ultrasound do? So there are patients who are very young. There are patients who are pregnant. And there are some patients who have certain changes in the breast. We cannot do a mammogram because a mammogram involves compression of the breast.
And causes, yeah.
If a patient has an open wound, if she has an infection, if she has had a surgery, you cannot do a mammogram. Then for these patients, we do an ultrasound. Every patient under 40 and children and pregnant and breastfeeding, we always start from ultrasound. But apart from that, mammogram should be the first line. Usually 40 and above, if a patient comes with symptoms, we do a mammogram. She's not 50, but she has symptoms, we do a mammogram. 30 to 40, we weigh the benefits. Okay, what is the problem she's experiencing? Sometimes we do limited. So standard mammogram without a tomosynthesis, there are 4 views. We do a craniocaudal of each breast, and we do an MLO, mediolateral oblique. These are different views of the breast, and they allow us to triangulate, like, is it present in the upper outer breast, lower outer breast, upper inner. So these are the standard views. Now, ultrasound, like I said, so ultrasound, we also use it to, if we see a mass, then we can do it. We do an ultrasound. Is it solid or is it cystic? Ultrasound will tell us. Sometimes we don't even see the mass on ultrasound, actually. Then it's a dilemma because we saw it on mammogram, but we don't see an ultrasound, what to do. Then we go on to MRI, and sometimes MRI shows us. Microcalcifications are one thing. We don't see them on MRI. We don't see them on ultrasound. Sometimes there's a mass associated with these calcification, and we can see them on both MR and ultrasound. But many cases, we don't see anything associated with these microcalcifications. Then we do a stereotactic biopsy, and we get different kinds of cancer and normal findings with these calcifications also. So that's why mammograms, they have a very high, this is research, this is literature, and these are the things that have been proven. And that's why only then is when these things, they bring them for the public, when they see that the benefit is more than the risk. So these are the benefits of a mammogram. So when we see these microcalcifications and we don't see nothing on ultrasound, then what we do is we do a stereotactic biopsy. We don't go towards MRI. It's too expensive. The chances of us seeing something is very low. So we just stop. Yeah.
Okay.
So, and what else? Now there's high risk women. High risk women are those that have a lifetime risk of breast cancer greater than 25%. Who are these patients? This is a certain group of patients. So for these patients, in Quebec, we started from 25 years. So from 25 years, we started screening for them. I will tell you what screening that is later. In Ontario, they started from 30 years. So these are those women who are gene carriers. They have done their genetic studies. They have family history of breast cancer in
close relatives, first degree relatives, multiple second degree relatives at young age, mother at 30 years, sister at 35 years, like that. And then they get this genetic testing, BRCA1 and 2 carriers. There's P53, there's P10, different kinds. So these are those high-risk women. They have had the genetic testing. We know that they are gene carriers. They are at average, greater than average risk. This is number one. Number two, first degree relatives, like the mother has BRCA1. She has a gene for high risk. So her daughter, she is a high risk. Then these assessments are done by genetic clinics. And we had one at McGill also. Then the other patients are those that have had radiation therapy to the chest. Like, for example, they had a lymphoma in childhood, or now they are 30 years, and when they were 20 years, they had radiation to the chest for whatever reason. So if 8 years have passed between the radiation, they also fall into the high risk group. So for these, there are different programs that are done. So in Quebec, what we used to do is when they turn 25, we start doing their MRI breast. And they have ultrasounds also, but we don't do mammograms for them normally. Here in Ontario, we do MRI. And for some patients, we do ultrasounds also. And for those patients who are 40 and above, they have both mammograms and both MRI. So if they, and if a patient cannot have an MRI, like she has a contraindication to MRI, or she's claustrophobic, or she's allergic to contrast, then we do mammogram and ultrasound. So these are the high-risk patients.
Okay.
So in the US, they start screening for breast cancer at 40 years. Ours is 50 years.
50.
Okay.
Yeah, and it is second most common cause of cancer death. Second most.
Wow.
Yeah.
Still, after so much studies have done, it is still the second.
Yeah, you know what, the reason for that is that, okay, Canada, US, if you have the developed countries, the programs are good, but worldwide people don't have these facilities.
Yes.
Everything you have to pay by yourself. You have to people can't afford all the treatment.
Yes.
So when we talk about breast cancer, we talk about the world generally, because we cannot think that because we are doing better than others, so everything is under control. We cannot close our eyes. It's not like that.
It's not like that. Yes, definitely. Wow.
Yeah. And another thing, we're very lucky here in Canada too, because someone is diagnosed with breast cancer, you had a wide variety of team that support that woman.
That supports them. Yeah.
The cancer care is amazing. Okay. So what happens is that we have different kinds of things. If she's having some swelling in the arm after the surgery, there's a different person who is going to look after her. There is a social worker who is going to see that she is well, she can manage all her household things, what she's going to do after surgery. So everything is taken care of. When a patient comes to a hospital to have her surgery, she has a big team behind her.
Yes.
It's supportive. Everyone is very supportive here. Yeah, that's very good. Yeah, the programs are excellent actually.
Yeah.
Okay.
See, Teresa, you have to move to Quebec now. I told you, Quebec is the best. See, you have to move over here.
It's all of Canada is good. They have very good screening programs, and patient care is number one. We at our center, we are very, very careful that patient care, there shouldn't be no compromise with patient care. Yeah.
Quebec is the best.
And what's your success rate there?
Success rate in terms of what?
Recovery from breast cancer in your area or your
You mean in Quebec? You mean in Quebec?
Where she's yes, basically in Quebec.
It's difficult to say for Quebec exactly because I'm now in Ontario. I was in Quebec before, but now I'm in Ontario. So
you're in Ontario now. Okay.
Yeah. But for
Oh,
Quebec,
you're in Sudbury, you said, right?
yeah, yeah,
Yeah.
yeah.
Okay.
So for Quebec, what it is that you know that all women do not get screening done. And then there are some, this year was exceptionally not good because we
Yeah.
had a lot of cases
Yeah.
which came immediate, a lot. And it
Yes.
was very, very distressing because the clinics were closed, the doctors were closed, our breast center was closed, we were not accepting
Wow.
patients.
Yes.
And
Wow.
when we got the patients, we would ask them, and they said they had symptoms for 6 months, 8 months, 9 months. 6 months
Wow.
been struggling to get to a doctor, to get to a breast center. So this year is exceptionally been because of COVID. But now what happens is that it looks like it's going to stay there for a while, COVID.
Okay.
So we have, made everything. We have, worked around that, and now we take our precautions, but we are doing our normal breast service program. We are doing everything as we would do if COVID wasn't there. We have come to that, but it was after
Oh,
1
good.
year.
Yes, that's good.
But it was after 1 year, I must say. And initially, like, nobody knew what COVID was, and everybody was scared, and and we didn't have much protocols. We didn't have personal protective equipment, so everything came to a standstill. But thankfully, we are moving again. So
Yes, things are opening up
Yeah.
back.
yeah,
Yeah. Mm-hmm.
As Dr. Shikari was, Dr. Shikari?
Shaista.
As Dr.
Shaista.
Shaista was saying,
Shikari.
okay, I apologize. I
She's
feel
horrible with names. Horrible with names. Never get a name right.
that's so true. That's so true. She's correct. As you're saying that because of the pandemic, surgery has to put on hold, and during that period, I know someone. She's an acquaintance of mine. Her mom died because everything was at standstill right here in Montreal. Yeah.
yeah, yeah,
Unfortunate.
Yeah, that's that was one of the saddest part, but
yeah,
it's sad.
Yeah.
yeah. That's
So,
true.
Shaista, can you explain the difference between the screening system and the CRID? Because we have both the
Yeah.
CRID and the yes.
So the screening system, normally we don't do screening at like the McGill, but screening is allowed at different centers which are approved by Quebec breast screening program. So what it is that they're going to visit your facility. They're going to make sure that your machines, your views, your technicians, everything is good. The machine, the radiation dose it is giving is within the limits that are approved. So these are present at different places in Quebec, different clinics, different small private hospitals, and they don't charge you. So as long as you have your Quebec health card, that's okay. So then the CRID is, Lisa, I'm not much familiar with the CRID. I know that at McGill, we are mostly doing diagnostic mammograms and referrals outside. So what happens is that when a patient is referred because of some high risk factors, then she is referred to our center. They bring their CD, their images, and then we look at that. We would look at that at McGill, and then we do further studies, biopsies, or whatever is required. So then they refer them on through the GRID program to big university hospitals, big facilities where they are surgeons, they are radiation oncologists, and those are for those patients who are highly suspected or they have abnormalities on their imaging done outside. Sometimes they're biopsy proven cancers also.
Yes. And if you don't mind explaining the how we categorize lesions or benign and malignant lesions.
Yeah. So we have a BIRADS system, breast imaging reporting and data systems. It's called BIRADS. It was developed by the American College of Radiology. So BIRADS was developed so that everyone uses that universal terminology. Like when we say stop at a traffic light, yellow, everyone knows what yellow means. Everyone knows what green means. So BIRADS is like that. So BIRADS 1, I'm going to start from 1. It's from 1 to 6, and then there's a 0 also. So BIRADS 1 means negative. Negative, by negative we mean there's nothing on the imaging study. It could be a mammogram, it could be an ultrasound. So we will say bilateral breast ultrasound, BIRADS 1 at the end, negative. So anybody reading it knows this is a normal ultrasound. Then we say BIRADS 2. So when we say 2, it means benign findings. So what are the benign findings? Benign findings means that there is a finding, but it's not cancer. We are sure it is not cancer. So then we call it benign. So it could be a cyst, it could be a fibroadenoma, it could be anything else except cancer. So that is BIRADS 2. Then we say something BIRADS 3. When we say BIRADS 3, basically what we are doing is we are thinking that this is probably benign. It's probably not going to be cancer, but if we want to follow up something to make sure that it stays like that, it stabilizes. So what happens is that we put the patient into BIRADS 3, and then we call the patient back 6 months follow-up. Like for example, if it is abnormality on a mammogram and we say BIRADS 3 to it, then she's going to have a mammogram at 6 months, then the next one again at 6 months, then at 1 year. So we will follow that patient for 2 years. That is what BIRADS 3 means. And after 2 years, if something is stable, then we are quite confident this is not cancer. So when do we do this? Like we have very young patients who come and they demonstrate a solid cystic thing. We know she's very young. So probably it's a complicated cyst. So we're going to put her into BIRADS 3. We follow her up for 2 years, and then we know, oh, this is all good. She's stable, so it's okay. Again, on mammogram, sometimes we have calcifications. So now what happens is some calcifications, they don't look suspicious. But initially when they are coming on, we need to make sure that which way are they going to be? Are they going to become like really benign ones, like nothing cancer, or are they going to become suspicious? So what we do is, again, we put them to BIRADS 3, and then we do 6 months mammogram, then again 6 months mammogram. It's only going to be that breast, one single thing, maybe left.
Okay.
And then when a 2-year follow-up is complete, we'll say that this thing in the left breast followed on the mammogram for 2 years has shown a 2-year stability. Patient can return to routine screening. So that is BIRADS 3, in which the patient is followed up basically by whatever form. If it is something we saw on MRI, again we do the same thing, is we put her to BIRADS 3, and she'll come back for MRI 6 months, then next MRI again at 6 months, and then an MRI at 1 year. So 2-year follow-up. Okay, BIRADS 4. Now BIRADS 4 means suspicious. It is something that is suspicious, and we are going to biopsy it. Whenever we have to biopsy something, we put it to BIRADS 4. You cannot say BIRADS 3 and biopsy it. No. You cannot say BIRADS 2 and biopsy it. No. Whatever you have to biopsy, it has to be put into category 4 before you can biopsy it. So in 4, there are categories of A, B, and C. Okay. So when you say A, you're not very suspicious. Maybe it's a fibroadenoma, but it looks a bit different. So you put it to A. B is usually we put it for microcalcifications. We're not sure, are they going to be benign? Are they going to be something cancer? So we put it into B, intermediate. And when you put something into C, you are about 80 to 90% sure that this is going to be malignant. So then you say C to it. When you put a patient into BIRADS 4C, she is going to have a surgeon referral also here automatically. So as soon as you say C, the patient is going to get a surgeon, whatever the result of that biopsy. It means you're very suspicious on imaging. Then there's a BIRADS 5 category, which is highly suspicious for malignancy. That is cancer. We cannot, because we don't have the pathology, we cannot say cancer to it, but we are about 99% sure this is cancer. Whether it is on ultrasound, whether it is on mammogram, whether it is on MRI. So that is BIRADS 5. Now BIRADS 6, when you have biopsied it, it's a cancer. You say BIRADS 6, biopsy proven cancer, right breast or left breast or whatever, both breasts, whatever, like that. So BIRADS 6 is biopsy proven cancer. Now there's one category, BIRADS 0. So 0 means incomplete. You have not been able to evaluate the patient completely. So when do we put 0? The patient has come from outside. She has a mammogram, but she doesn't have an ultrasound. And we need to do an ultrasound to determine this abnormality is what it is. So we're going to put her into 0 and we say incomplete. And what are we going to do? Additional imaging for right breast, including ultrasound, this, like that. Okay. Barrett 0 is also put when we see on a mammogram, we do a mammogram and we see a mass. We don't know what it is. We'll say that Barrett 0, ultrasound will be done. And we are going to complete, after the ultrasound, then we give a Barrett's that no, that was a cyst. And so she's Barrett's 2 now. So whenever the imaging is incomplete or you are waiting for patient's prior imaging films, for example, you did a mammogram, but her outside mammogram is not available to you, we'll put her into 0 again. We'll say we are waiting for prior images. So 0 is incomplete always.
Yeah.
Okay.
These are the Barrett's category, and they are applied to every imaging modality we use, whether it is mammogram, whether it is ultrasound, or
Ultrasound, MRI. Okay.
Yeah.
Okay. Let me ask you, what would you say to women who are not able to get a mammogram? A mammogram or ultrasound? What would you say to them? How can, what would they do? What could they do? I mean, self-examination. A lot of people don't really know how to do self-examination properly. So what would your suggestion be to women like this who's not able to facilitate these things?
Okay, so I want to tell you one thing is that previously breast self-examination was, they were quite giving it like they were saying that women should do it, and but now they say no. They say your doctor has to examine. Because
the doctor does it now.
the doctor has to do it because there were a lot of false negatives, and there was a lot of what happens is that if you don't know the technique, you're going to palpate the glandular tissue, you're going to palpate different things, and then you're going to think you have a lump. Then they come and they start getting being investigated. So the false negativity was a lot. There was anxiety associated with it. So now they say your doctor has to do it.
Okay.
Yeah. Because you cannot do it completely yourself, number one. Number two, you have to be lying down flat, and then with the palm of your hand, you have to check it. You can't do that yourself properly. Either you're not doing it completely, or you're not doing it in the proper way. You don't find things, or you find things that are not real.
Okay.
Yeah.
So now it's best for the doctor to do it. You ask your doctor to do it.
Yeah.
Yes.
The other thing is that mammograms, I don't have a solution to say that a woman cannot get a mammogram, because even in underdeveloped countries, mammograms are available now. So I know the only good reason one could not be able to do it is if they can't afford it in countries where
it's the cost. A lot of people, because we have people here from the Caribbean who are watching, and a lot of them, the cost is way above them.
Yeah. So what it could be is that those people who have a strong family history or who like had any risk factors for breast cancer, I mean, they must get it done, I must say.
Yeah.
Yes.
And if you can afford it, at the health is number one. So if you need to cut down on your clothes or on your like food, not the one that is really not the unnecessary one.
The unnecessary things, yes.
Yeah, because you need it once in 2 years, see?
That's true. Yes.
Yes. 50 years.
Save towards it.
Yeah.
Save towards it, yeah.
So if you can save in 2 years for one mammogram, I think it's
right.
Yes.
I would not say. But
Dr. Shaista, I had a talk show recently, and the lady, she has some medical issue with her womb, her ovaries, and that was one of my line in the conversation. We women has to put our health first.
Yeah.
We have to have priorities in line.
Yeah.
Yeah. Definitely.
Yes, and that is most important. Yeah. Some people cannot. That's the hardest thing to say, but it's a fact. Some people, they cannot.
honestly
It's
cannot
really
afford
hard.
it.
Yeah.
Yes, it's
Honestly, cannot
really
afford
hard.
it.
Yes. So
I really I hear you, and I understand that there's some who cannot do it in spite of everything, but every person who can do it should make an effort. And
Yeah,
right.
yeah,
like I do think that there should be more support for women in this regard. I know breast
Yes.
cancer
I think so. I
affects
think so.
I
I
think
think
that in the
what
countries where the program is
what
not like there are no free programs available, like there should be like organizations which kind of work towards women's health and pay for the
yes,
women to have mammograms. I know there are some places they have mobile mammograms actually also,
Okay.
they go to
Oh,
areas and they do them where the woman cannot come out to get them done. So I just wish that we could work more towards that, because that is really something that is very important.
yes,
yes,
yes, yes.
definitely. Yes, yes.
It's just as though we have the mobile clinic check in Quebec. You know,
Yeah,
Teresa, here in Quebec, we have a mobile clinic that
yeah,
drives the
Okay.
community. Yes, for
And do
people.
these examinations and checkups.
yeah,
No, not really. They just do the basic, you know. They just do
Yeah.
the
Okay.
basic, yeah. For people, especially like, they feel like they're not welcome in the hospitals or for different reasons they do not want to go so they can
yeah,
reach
So
the
they do like
mobile.
cholesterol,
yeah,
Yeah, yeah,
cholesterol, high blood pressure, those
yeah,
kind of things. Okay.
yeah,
Okay.
yeah.
Okay. That's good. That's
Yeah.
very good.
And just to make a point, when a woman is doing her mammogram,
Yeah.
sometimes we do the mammogram and we call the patient back, Shaista, you could explain how you guys, your protocol for reading mammogram. So, sometimes we call the patient back and the patient said, oh, you didn't position properly. You didn't, and we have to explain it's not about a positioning. The
Yeah.
radiologist always
yeah.
compare the
Okay,
last five, and if there are changes, then you come back and focus on this different images. So you can
Mhm.
explain
okay.
how.
So when we are doing screening mammograms, what happens is that a woman comes, she has 4 standard views, 2 of each breast, and she leaves. Okay, now on Friday, I had 46 screening mammograms to read, which I did at the end of the day after
Oh,
5
wow,
p.m.
Teresa.
Okay. So
Wow.
what happens is that I am going through them, and there are some in which there are changes. So most of the women I was looking at was every 2 years, right? We are doing them at every 2 years.
Yeah.
So about 90% were those women. So now I'm looking and I see that a woman's mammogram, there's a new mass. In the interval between the 2 years, I see a new mass. So what happens is that I flag it down. I'm going to say that we're going to need additional views. What we do is we do laterals, and then we focus that area, and then we compress it so that we see how the borders are, and we make sure that it's a real abnormalities. Because sometimes when you are pressing the breast, you compress the glandular tissue in such a way that it creates false shadows also.
Mm-hmm.
Oh.
So what
Yeah.
happens is that we do additional views. We say that this patient has to be recalled back. We put her into BIRAT 0, incomplete. And
Mm-hmm.
then I'm going to say pending right breast spot compression or additional views. And then I want a right breast ultrasound, whatever I think she's going to need. I'm going to
Okay.
write, and then they're going to call the patient and they'll say that you need to come back to the hospital for additional views. She comes back, we do the additional views, the abnormality is still there. Then what do? We're going to do her ultrasound. We do her ultrasound, we find a mass. We biopsy it, and that's it. That's how it works. So these recall views are not because they are somebody's fault or it's because they were not done properly. It's because you have detected an abnormality and now you want to clarify it, whether it persists or it goes away when you look at it in different views. So that's why we do these additional views.
Yeah. And then this is
Okay.
another reason
Okay.
why when we do the mammogram, we need to compress as tight as possible. I
Oh.
mean, we're not compressing because we want you to have pain. Because if we do not compress properly, there's the chance of movement, right? So the breast looks very noisy, or the edge is not very sharp. And then, as Dr. Shaista said, if we don't compress well enough, then we create this breast tissue that looks like something.
Yeah.
Dr.
That's why I had an ultrasound, because I heard it was painful. So I'm like, oh, I can't take the pain. I can't handle pain.
I just did one. I just did one. When was it? Last month, I think. I just did one, and when I stood, it was really painful. And she said, "I'm gonna let you sit, Nadine." And I sat, and it was not that bad. It was okay.
It's not that bad. It's not that bad. It's worthwhile. It's just for 5 minutes. It's just for 5 minutes. It's worth it.
Yes.
It should, in my opinion, this thing that it's not what you call it. The pain factor should not be there. No.
Like I always joke with the patient.
Yeah.
Dr. Shaista, when you had yours, was it painful?
I had mine. I'm not there yet.
Oh, you haven't had one. See, that's why you can say that.
That
is not painful.
I had a biopsy. I have a clip, and there's no side effects. It wasn't that painful for me. Like I always joke with women. I said, if it pains to be beautiful, it should pain for your health, right?
No, I don't do nothing painful. I do nothing painful. Nothing.
But when
I'm scared of pain.
Dr. Shaista, I'm going to share my story with you. You won't believe this. I felt the lumps in my breast, okay? So I figured out it was liquid. So when I went to the ER, because it was so painful, I went to the ER. So immediately they said, okay, they do everything. And they told me to come the following day, which I did. And they found out it was liquid. I did the pressure,
the mammogram.
I did a mammogram, and then I did the ultrasound. And right there and then they removed the fluid from both breasts. Okay. 2 weeks after, I start feeling pain again. And I'm like, what? So I have to go back to the emergency. When I went into the emergency, my breast was swollen. And they found out that it was infected.
Yeah.
So from when they did the aspiration.
The mammogram?
No, the aspiration.
To take the fluid. Yeah.
So when they removed the fluid, remember they just dead in the body. I didn't sleep or anything. So it's the same day. Yes. After the ultrasound, they just did right there with a needle. So you do not need to get an appointment because you're right there already. So they did it. Yeah. But I had infection, and that was painful. The infection. Oh wow! I was in emergency the Friday night, and I remember on Fridays, over that section they're closed. They're closed on Fridays, right?
You went to the emergency?
Yeah, I went to emergency, and then they sent me over to your department.
Breast center.
Right. And they're closed over there, but they had to take my case because it was emergency. So immediately they sent me upstairs. I went and they pulled out all the liquid again.
Wow.
Yeah.
Wow.
They gave me antibiotics. So I went to remove the liquid, end up with infection. Then I had to go back to get antibiotics.
Oh my goodness.
I was walking like this in pain.
Wow.
Yeah. That's just a complication that can occur with any intervention. Any intervention you do, it can lead to a complication. So that's why
gosh.
when we have to do them, not otherwise. And that risk is very low. Like we have done maybe hundreds of procedures in the last month, but I think we had one patient with complication.
So
I think
the rate is very low.
Yeah.
Wow.
I think for me, my body is very sensitive because it's a great hospital, Teresa. It's my #1 hospital. Okay, nothing is wrong with the hospital. They treat me well.
I'm talking about a hospital. I'm talking about the procedures.
I'm talking my procedure. I'm talking me. during the process, I think, something went wrong. I have a very sensitive body. My body is very sensitive. So any little thing, it just go the opposite side. So I'm left. So cases like my case, maybe 1 in a million.
Yeah, very less.
Yeah,
Exactly.
right.
Yeah.
I'm very sensitive.
Agree.
Okay. So, any other questions or any?
No.
Anyone have question on the live? Anybody in the live has question?
No.
Dr. Shiraki? Yeah, Shaista.
Yeah,
Yeah.
Dr. Shaisa, we're gonna fix our Facebook, and we are asking you please to come on our Facebook again, okay? We don't know.
I don't have a Facebook, but I was using my son's thing, so
Oh.
I don't have time for that. I'm sorry. I
Yeah,
don't.
Very busy.
yeah.
Very busy.
Yeah,
So,
so I will use my son's ID, and definitely whenever the next one is scheduled. I think the Breast Awareness Week is coming, so I think we really need to
yes,
do
yes,
something
Okay.
with that.
Yeah.
yes,
Yeah.
yes,
So
Okay, that's great. It was great having you on.
yes.
thank
Oh my
This is
God.
amazing
We
information.
have to say thank
I have
you.
learned a whole
Yes.
lot too.
yeah,
And the
yeah. No
presentation,
worries. No worries.
we really, really appreciate you.
Not no
And
worries at all. Thank you so much for inviting me,
yes,
Lisa. It was nice to see you.
Nice.
yes,
Take
nice
care
to meet
now.
you. When you coming back to Quebec?
I have to come and visit Lisa and everyone. I might come in a month or two. I just came in
Oh,
July, I left there on 30th of June. So I really
Okay.
miss terribly.
Yeah.
Great team and
Okay.
great support and very good. Very good.
Okay. Yeah, Lisa's very good. She treats me well
She's
when I
very
come
good.
to the hospital.
Yeah, she's
Yeah,
very
because
good.
I'm a cry baby. But
Yeah.
when they touch my body with that metal thing, I cry. So they treat me.
no.
I cry. Yeah, I cry. You should see me with the doctor in the room. I cried. Yeah.
Okay. So, thank you very much.
Yeah. Thank you, and keep safe.
Sure.
Yes.
Keep
Okay,
safe.
Dr. Shasta,
Thank you,
great
Doctor.
meeting you.
Yeah,
Thank
Was
you
thank
great
so much.
meeting
you.
you.
Same here.
And
Same
I
here.
have to say thank you on behalf of my audience too. I know my audience want to say thank
Yes,
you. From,
definitely.
yeah, from worldwide, everyone is saying thank you.
Thank you so much. Thank you.
All
Bye.
righty.
Thank you. See you
Bye
soon.
now.
Bye, Lisa.
Okay. Bye. Yes.
Bye.
Okay. Bye, Teresa.
Yeah. So everyone,
Okay.
are you listening?
Uh-huh.
Yeah. So I think we have come to the end. No one wants to ask any questions in life. Well, I
I
think
guess she answered. I guess all the questions were answered.
yeah.
So
So no one is questioning it. So I thank God
yeah.
everyone. Instagram doesn't close my account like an hour. My show goes continually. So that was very good, Doctor, tonight. They don't close my show down. No. So we're lucky that we could have this continuous talk.
Sure.
Yeah. So thank you, everyone, and be safe. And next time when I'm going to go on Facebook, I'm going to send my information, and hopefully we can all meet again on Facebook.
Sure. Sure.
Yeah.
Thank
Thank
All
you. Good
right.
night.
you,
Bye.
everyone.
Thank you.
Bye.
Thank you. Take care.
You
Bye.
too, everyone. Bye.
Bye.
Okay. Bye now. Bye, guys.
Bye.
Okay.
Okay. Bye.
Bye,
All right.
Teresa.
Okay. I'll
And
talk
be
to you,
good.
Nadine. You'll be good
Yes.
now.
And before I go, I have to say thank to my hairdresser, Anita
Yes.
Reed. Thank
Your
you
hair
so
looks
much.
lovely.
Thank you. I have to say, Anita, thank you. If you come
Who
to
did
my
your hair?
salon,
Who did your hair?
Anna, my hairdresser, Anna.
What's her salon name?
Her salon is called, hold on, this is my bag. Her name is Anne. I'm going to take a picture and put her card up. And if you're on my live, I'm so sorry. It's called, it's called Different Style. I follow her. She's on Instagram, Different Style. And her name is Anne.
Oh,
Yes.
your hair looks lovely.
Yes,
Yeah.
thank you,
Your hair
guys.
looks
Yeah.
good.
But thank you. So I did it, and she makes me look beautiful today because it's Women's Month.
Yes, you do. Your hair looks amazing.
Thank you. Just as you guys. So we have to say, so next week, I have some interesting topic, guys, but because I've been so busy doing other projects. You know, I'm always doing some research somewhere. I'm always finding something to do on the internet. So, but I have some guests that wants to come on my show to talk about their real life issues that they're experiencing.
Okay.
So, yes, I got some people that wants to come on. So I'm trying to make time. So hopefully soon I'll be able to, guys. And Instagram, as I said, do not close my account. Do not shut our live down. They let me go through. Thank God. I don't know why.
That's good. That's good.
Happy. And so our platform, this is what we do. You know, we try to reach out to everyone. No discrimination against anyone. Doesn't matter your race, your gender, your sex. Come on over. Share our live. I post everything online, so you could share it with your family members worldwide if they want to come on my show live. Because everyone that comes on our show, I never know that. I never met them before. To be honest, guys, everyone that comes on to talk about their life stories, I never met them before.
Okay.
I met them on Instagram right here.
Okay.
That's really good. That is really good. That's really good.
Everybody to share their experience.
Yes.
We either learn from it, gain some kind of insight. So it's good.
It's good.
Everybody's experience is different, so it's really good that they want to share with others.
Yes, Teresa, Teresa, Nikki and Vanessa, you know, I know those people before because Vanessa spoke about their story. But you know, those are my friends that I know a long time ago. But 90% of the people that come to the show, my first time
on your show.
Yeah. So happy to be careful listener this event.
Chef Rodney. Okay, I hear you.
Yeah, thank you, Chef. Yeah, we heard you. Thank you. So I'll keep you guys posted, and God goes with you, and be safe, and thank you for coming. And we have to thank Lisa also.
Well,
yes.
Yes.
Thank you. Thanks, Lisa. Thanks for coming. Loads of information there.
Yes. From last night, we've been working together. She came
yes.
And I cooked supper for her, guys. Okay.
Oh,
yes.
Can't wait.
How was it? How was it, Lisa?
I haven't tasted it as yet.
Okay, you're gonna eat after. Okay.
Yes.
Okay.
I cooked a lot today for her.
Oh my gosh.
She's just coming from work. She has to take care of patients. You know, this is what she
I know. Yeah.
Woman, you know. Women.
Okay.
It's all about women's health, guys.
You know, it's all about women's health because, you know, our health is very important.
And guys on the show, please encourage any female members that's in your life. Please encourage them. Your sister, your mother, your wife.
Go get a mammogram.
Go and get a mammogram. You never know.
I'm getting mine. Ultrasound is not enough. So I'm going to go get a mammogram now. Because the ultrasound, you say, is not enough. So, okay. I'm going to do the mammogram.
So do that, guys.
I'm going to do the mammogram.
That's good. I want to hear about it. Yeah. When you get your mammogram.
I would love to hear
I am. I definitely am.